to welcome you to this echo endoscopy, G-echo endoscopy session, which today will be regarding gastric polyps and how to deal with them. A relatively common problem, but with a few quandaries that I'm sure we're going to have resolved for us by Galia and Matt. It's my pleasure really to tell you that we've got 48 registrations from 15 countries, from Bangladesh, Uganda, Zambia, Namibia, Nigeria, and Peru. So welcome to all those who are actually logged on at present. And this is obviously on behalf of Project ECHO from the University of New Mexico. This is our regular slot on a Wednesday, and next week will be the pathology session. And please, we really do want you to participate in any queries or quandaries you have about what's presented to you. So please enter any questions that you have into the chat box as we go along. And so we'll move on now to the actual presentations, and the presentations will be shared between the two presenters, and as usual they are going to give us an informative session on gastric polyps, their spectrum and management. Matt, over to you. You can start your screen share now. Thanks.
Can you see the screen?
We have your presentation in front of us now in the presentation mode.
Thank you. Good afternoon, everyone. It's Galia and Matt, and as Prof said, we're going to take you through a bit of an approach to a fairly common problem. We're hopefully going to make it a little bit more interesting than it sounds. What we're going to do is we're going to share it a little bit. We're going to do one half sort of practical videos that we've come across, situations, how we've managed them, and then the theory on the other side. So please ask us whatever you feel like at the end, but hopefully you'll go back and look at your polyps with a little bit more excitement next time. So just to remind us all, I think the epidemiology is, if you really look at it, it depends obviously where you are based, but up to a good quarter of patients on a normal endoscopy list may end up having an unsuspected polyp. Now, those are the three most common things that we find: Fundic gland, hyperplastic, and adenomas. And we'll take you through those individually. But I think you'll all agree, generally speaking, clinically, most polyps will not be symptomatic. It's really that they do come with anything, and if so, it's because of their size. They may present with some bleeding, usually anemia though, obstruction on the odd occasion, and some vague sort of epigastric discomfort. Just as a broad starting point, obviously you should confirm histologically what you're dealing with. Biopsy anything that's smaller than 5 millimeters. There's consensus as regards the size of 10 millimeters and over. Those you do need to perform a formal polypectomy out. Very important, don't forget to randomly biopsy the supposedly normal gastric mucosa in between the polyps for pre-neoplasia. And then, of course, don't forget the ever-present culprit, H. pylori in the background. I do think you need to be able to speak the language, and to do that, you should be able to describe your polyp both for yourself when reviewing on another occasion that same patient, but also to describe accurately to colleagues who may scope that patient on another day. I must confess, I don't remember the Paris classification offhand and prefer to verbally or use descriptive words, but you should be knowing about it, especially if you're going to be writing your exam soon. In addition, the Kimura Takimoto classification, remember that as regards staging atrophic gastritis. And then the Sydney protocol as regards correctly biopsying, and those spots 1 to 5 correspond to the location of the gastric biopsies should you go and flatten out your stomach like a pancake. So let's start off. Fundic gland polyps. You'll agree these are very common, and up to 23% of upper endoscopies will present with some number of fundic gland polyps sitting in the corpus or the fundus. Usually middle-aged women, they're usually quite small, less than 5 millimeters, sessile, they may be single, and if multiple, there really is there are quite a few of them, as I said, body and fundus, and most of us can quite comfortably and accurately identify them on scope. They're often similar or lighter in color to the surrounding mucosa. And if you switch on your NBI, you actually get a very beautiful, lacy picture of the blood vessels through that translucent surface. I've put this gland in here just for you to try and remember which is which. I've got a bit of a not the best memory. So for me, fundic gland polyps, obviously fundic, they on the proximal end of the stomach. To me, they look a little bit like a washed up jellyfish. And the way I remember that they're usually middle-aged women. If you look at that picture on the left, that's just a random picture off the internet. If you Google middle-aged women, and they've all got the same haircut, looking a little bit like it's kind of jellyfish shape, shoulder length hair. So that's to remember what they look like. Fundic gland polyps microscopically are pretty normal cells. Essentially, there's very little atypia or anything like that. So they're just disorganized but normal, essentially looking cells. And I think the big thing to remember here is that their malignant potential is really, really low. And if anything, it's only something to be concerned about in something that is bigger than 10 millimeters. Remember the good, sturdy, middle-aged woman. She is faithful to all. She does not associate with a whole lot of bacteria. That's the way to remember. There's no H. pylori association. Syndromic association. Please consider if more than 50 polyps, and then please remember to evaluate your patient for FOP. If you get like a carpet of proximal polyps, more than 100, then please evaluate for gaps, and we'll talk about that just now. Management for all of those of us that like confirmation, I would always suggest at least having one biopsy, and then you can follow up that patient, but please do biopsy the smaller ones, and if you've got a bigger one, take the whole thing off. Then if there's no dysplasia, well, that's great. Then you can consider conservative management unless you are evaluating for FOP. If possible, some recommend to discontinue your PPIs, but I think most of you will agree that most patients will prefer to continue. And then, you do need to biopsy the surrounding mucosa to exclude pre-neoplasia and H. pylori, but generally there's not an association. This is just a picture of gastric adenoma and proximal polyposis syndrome, and that's just to show you that you can understand why people might confuse it with multiple fundic gland polyps, but this is a bad situation to be in, and in this case, we would recommend a prophylactic gastrectomy, as the chance for gastric CA is incredibly high. Let's move on to the next one, hyperplastic polyps. Now, these are approximately making up 40% of gastric polyps, very high H. pylori prevalence, often with a stalk. They're not nearly as uniform in appearance as fundic gland polyps. They're quite reddish in comparison to the surrounding mucosa, and that vascular prominence is quite clear. If you're lucky, you'll see that quite nicely. To me, I find they look like angry mushrooms. They're often with a whitish inflammatory fibrin spot on top. And you can imagine them waving around with some friction and so forth with movement of the gastric wall. And I can see that kind of situation causing anemia over time. They're usually larger than the Fundic gland polyps, and up to 30% will actually be bigger than 10 millimeters. They may be single, and if so, then they're stuck in the antrum. On the other hand, if you've got multiple ones, then they're usually throughout the distal stomach. And as we've said before, yes, there's an H. pylori association. They are single, they're lonely, they like bacteria, H. pylori. Remember it like that. There is some evidence that if they are small and few, you may regress them with eradication of H. pylori. They are rarely symptomatic, and only if, as we mentioned, if they're large and waving about with friction, they may cause some ulceration and anemia.
Okay, so we're going to intersperse this with a few cases, just hopefully to keep people interested. So these are some real patients to show what polyps can actually look like. So this is a 55-year-old female who presented with a 2-year history of quite vague symptoms, a bit of epigastric pain, dyspepsia, sought some healthcare at one point, was given empiric PPI treatment, never had an endoscopy, and importantly is a smoker, also hypertensive, and then finally was referred for endoscopy because she was noted to be anemic with a microcytic anemia. So here's a video of us in the stomach, progressing to the antrum. There's 1 or 2 spots of redness, which might suggest some gastritis, but as you come to the pylorus here, there's a pedunculated, very large polyp that's almost occluding the lumen, going down into D1 here. And this is a very typical appearance of a large hyperplastic polyp. And as Galia said, because it's been waving about, the tip was slightly ulcerated. It's not so easy to see here, but that's a good reason why this patient was anemic. So we're going to carry on talking about hyperplastic polyps, and then at the just now I'll show you what we did for this case and how it ended.
Yeah, so as Matt said, the big solitary distal hyperplastic polyps can actually present with intermittent intussusception, vague epigastric pain, sometimes with vomiting immediately after a meal. And you can see it, it's sort of a ball valve effect happening there. And we've done a few patients like this. Matt will show you just now. Microscopically, hyperplastic polyps are a little bit more irregular as when compared to the Fundic gland. There's more inflammation, a little bit more regeneration, and obviously for those high turnover situations, there is now a definite real malignant potential. Yes, it's low, but it's definitely there. Size is the big thing. So of all the ones biopsied or resected, you'd find up to a third can have intestinal metaplasia. And then as you go down to the more severe situations, 2 to 6% of the larger ones can actually harbor a small adenocarcinoma. So if you look at it overall, that is quite significant when you compare it to Fundic gland polyps, obviously. Then remember, interestingly enough, the risk of malignant degeneration in the surrounding mucosa of a patient with hyperplastic polyps is actually much, almost as high, it's sitting at 7.1%. Let me correct that, it's actually a bit higher. So that's concerning. So remember always to biopsy the surrounding tissue. So management-wise, if they are symptomatic, as our first picture was, or if they are more than 10 millimeters, or you've had a previous biopsy suggesting dysplasia, well, obviously you need to remove it. If they are single or few, take them out, and your surveillance should be within a year to ensure no recurrence. If they are multiple, please do eradicate H. pylori if present, and again, come back in a year. And then as we said just now on the last slide, please do evaluate for pre-neoplasia in the surrounding tissues. Now, this is what you will commonly see. Might appear to be a daunting task if you've got an antrum filled with these things, but the recommendation is there. You should be taking them off if they're bigger than 10 millimeters. Don't tackle them all in one go, but you can take the bigger ones off this time and come back another day to take a few more.
Okay, so this large polyp I showed you just now, what did we land up doing? because it looked so friendly and inviting, we did a polypectomy here. We usually inject the base with a solution containing adrenaline, usually methylene blue. We didn't have that available here. The methylene blue gives you a nice view of where you've injected and helps you distinguish between mucosa and the underlying muscular layers later. Try use a nice big snare. You go in there and you find out you've been given a tiny small snare that can make it extremely difficult. Here use a nice big snare. Moving the polyp, seeing that it's mobile, and then using this is a hot snare, so using that away from the mucosa if possible. And the difficulty, of course, is that you can lose that entire specimen. So here we used an endonet to retrieve it, which was very satisfying. And then we took that whole thing out. Quite challenging sometimes to gauge how big the polyp is. You can use these instruments here are usually about 2 or 3 millimeters in size. That can give you an idea, or we compare it to the pyloric opening, which in most patients is about 10 to 15 millimeters. So you can get an idea. We retrieved this polyp, and it actually incidentally came back as having a focus of adenocarcinoma in the tip. The pathologist wasn't clear about whether the stalk and the base of the polyp was involved as well. So what we did, we went back and we re-snared a little bit of the base that was left, lost that specimen, unfortunately, and then went back, rebiopsied, and that was clear, which is very fortunate because in this patient, she was actually not a very good candidate for surgery. She was elderly. She had a lot of comorbidities, and we've managed her like that. We will survey her going forward. She didn't need any more treatment.
I'm going to mention now portal hypertension gastric polyps. And the reason I'm mentioning them is that they look very similar to normal hyperplastic polyps. I'm going to show you some pictures shortly, but the main difference between them on endoscopy is that the portal hypertension version thereof much larger and quite obviously very much more vascular. It's very easy to see that. Their clinical course, unfortunately, not really known which way they're going to go, but they do seem to regress when you get on top of the portal hypertension. And again, the recommendation is that you should be removing them if they are more than 10 millimeters. Unfortunately, they often do present much larger than that. And as with normal hyperplastic polyps, they may be sporadic or multiple and usually distal. What's a bit annoying about them, and that goes with the portal hypertension background, obviously, is that they do recur quite frequently. If you look to the left of your screen, those are the nice, pretty hyperplastic polyps, and then compare them to the portal hypertension version on the other side. Very vascular. You can just see if you're going to biopsy that, it's going to be a bit messy, much larger, but also all lying usually distally. And if you go close, you can appreciate that vascular appearance quite nicely. Again, on the left, a nice, beautiful, easy polypectomy, and then compare it to the right. When you take off one associated with portal hypertension, it's messy, they bleed, and you pop on quite a few clips. Not the nicest outing, not something I can recommend. I would rather send this patient to the liver team and get on top of the portal hypertension.
Okay, we're going to change tact slightly and give you another case just to give 1 or 2 points about endoscopy in general and where we can miss things in the stomach. So here's a 58-year-old male who came with a 2-year history, quite similar to the previous case, vague epigastric pain, dyspepsia, had been on PPIs for a long time, and importantly had some intermittent pain after eating and sometimes on occasion vomiting. So concern of intermittent gastric outlet obstruction perhaps, and he was also anemic, had a microcytic iron deficiency anemia. So as we went down, unfortunately, we don't have a video here, but we saw this large polyp area in the antrum in the pylorus that looked like a hyperplastic polyp, was snared off. It was a bit of a mess, needed to put 2 clips, and that was sent off. And fortunately, the endoscopist didn't forget to complete the scope and do a retroflexion, because as we did that, we noticed multiple other polyps, which are probably Fundic gland polyps. But importantly, is that when you retroflex, you should talk properly and do a full 360-degree view, because what is hidden here is quite difficult, quite easy to miss, difficult to see, is this polyp here that looks different to the others, and on careful review looked something like this, and this was actually an adenoma, was snared off an adenoma with the focus of adenocarcinoma in it as well. So an important case to show that you can have multiple polyps in the same patient, and just because you find the one polyp you think you've explained, probably have explained many of the symptoms, it's important to complete your scope and have a careful look at the stomach, especially in places up where you've retroflexed up in the fundus. Quite difficult to see that, easy to miss.
Okay, we're going to move on to adenomas. To me, they look a little bit like a fried egg that you've dropped on the floor most of the time. They're usually incidental, often sporadic. On the odd occasion, you might find them in a patient with a syndromic background. Usually elderly patients, and they are, as a fried egg, well circumscribed, well demarcated, usually benign. Yeah, and as we know, though, they are known as neoplastic precursors of adenomos here. So if you want to try and better differentiate, you can put something down your scopes. For here on this image, which isn't of ours, but here they used acetic acid, indigo carmine, and you can just appreciate the edges of it, of that distal antral adenoma so much clearer. As regards the histology, they're often in the antrum, as I said. The mucosa surrounding them is usually completely normal. And as in the colon, these adenomas may be tubular, villous, or tubular-villous. And they are neoplastic, and they may contain other dysplastic goblet cells, parietal cells, or even Paneth cells. So what do you do about them? First of all, I think it's important here to get a nice idea of the size, which obviously varies. Usually they are smaller than 20 millimeters. Maybe flat or sessile, usually flat in my experience. Very rarely are they symptomatic, and if so, they are the larger type. Is there an H. pylori association? No. Malignant risk? Most definitely, and again, it's very much dependent on size and as well as villous histology. And remember, though, importantly in this case, that depending on which series you look at, up to 60% may be associated with a synchronous gastric CA. And 28 to 40% of them actually may be neoplastic. So here it is really worthwhile to put a bit more effort into it. What should you be doing? You must resect them, irrespective of the size. Small, big, they must come out. Remember again to biopsy the normal mucosa surrounding it. Which way you do it depends very much on, to me, where is it situated? And obviously your personal experience, how happy are you to do an EMR versus an ESD? The EMR technique is quicker, it's easier for most of us to do. I think especially when you're retroflexed, you really have to be quite skilled to do an ESD. That's not something I would be able to tackle. I'd always have to go head on. And then in the duodenum, I think you need a very nice, happy looking adenoma to be performing an EMR or any endoscopic resection, because with an ESD in the duodenum, the perforation rate is pretty high. So I'd be careful there. I would probably go an EMR route. Remember here, it's very important to lift that thing. Remember, you must surveil these patients. They do recur. And if there's any evidence of any dysplasia or you didn't do a complete resection, please go back in 6 months. If you did a good thing and it's all out, well, that's fine. Then you can come back in a year's time. So just to summarize quickly, biopsy or polypectomy gives you the diagnosis of it usually being either a hyperplastic polyp, which you're going to treat if present the H. pylori. You're going to resect everything that's bigger than 10 millimeters. Fundic gland polyps, the old ladies and the washed up jellyfish up in the top, very common. If there's no dysplasia, only resect those that are bigger than 10 millimeters. You can consider stopping PPIs, and remember, if there's more than 50 or 100, please, please, please consider a syndromic association. Adenomatous polyps, we know, we just mentioned, there's a malignant risk, and you should take them all out and surveil. What about everything else?
Okay, so now we're going to look at a couple of other funny polyps. So case number 3 is a 73-year-old female that came with again, quite similar symptoms as the last case. So she had a 2-year history of quite pronounced epigastric pain after meals and intermittent vomiting. She really felt like at times we thought she had an element of gastric outlet obstruction, also a smoker, and had a history of hypertension and gastric and gout. And she had, on endoscopy, if you look at the top left picture here, this is a pedunculated polyp with a stalk that almost did a 90-degree angle into the pylorus, and really you could see it during endoscopy, was causing gastric, was causing an obstruction. So it really moved into the duodenum, and when you snared it and pulled it out, there was a large component of this polyp that was actually sitting in the duodenum. So important in this case was that this polyp was very, very big, and we were hesitant to resect it in the endoscopy suite. So she was done under a general anesthetic in theater. We snared it. There was a bit of bleeding at the base. This is the base here post-snaring. We put some clips there, and then we resected what looked like a little clog, quite a large polyp. I think the case here is that if you remove this in a patient that's awake and not paralyzed under GA, you can have a real risk of perforating things, especially at the OG junction, to get that through the OG junction and up the esophagus. So we were quite happy to have done this under GA. And the histology here came back not as a hyperplastic polyp, but rather as a Vanek tumor, which Galia is going to tell you about now.
So I think this is only the 3rd case that we've had in the last 10, 15 years that I'm aware of. So very rare. And as you can see here, they get quite chunky. From our case, definitely bigger than 3 centimeters. They are associated with adenomas, and most of them will occur distally as well, and quite pronounced within the pyloric channel region as well. Usually incidental. There's a massive eosinophilic infiltrative process. Why they're there, nobody really knows, but you should take it out purely by size. And in this case, obviously, this was quite a symptomatic one. There's no need for surveillance. Once you've got a complete resection, that's that. And there is, fortunately, no risk for malignancy here. A couple of other polyps that we should quickly, briefly mention. Juvenile polyps. These are mucosal tumors, essentially, haematomatous polyps. They consist of an excess of lamina propria and dilated cystic glands. There is often an inflammatory background. Again, they may be solitary, pedunculated. They can get quite large. There is a bit of a risk of dysplasia. There isn't, unfortunately, a clear guideline as how to proceed. So I think go with what's been proven. Anything bigger than 10 millimeters must come out. Anything smaller, you need to confirm with a biopsy. They do, unfortunately, look a little bit like hyperplastic polyps, that mushroomy look with a fibrinous little top. And you can quite easily confuse the two. So take it out and send it off. In Polyps, as you will recall, autosomally dominant situation, again, haematomatous type polyps, they can occur anywhere. As they get larger, you may even in the small bowel present with intersusception type symptoms. In these patients, a quarter or half of the patients will actually have some gastric polyps, or on the video, you'll see them there in the duodenum, quite small. They're usually small and usually not an issue for the patient. But again, there is that slight malignant potential. Again, no clear guidelines as what to do with them. But I think if you know this is a Polyps patient and you've got solitary manageable ones, do take them out. And this is a situation that you should probably be surveilling.
Okay, case number 4 was an interesting one. It was a 31-year-old female. She was a rather poor historian and had a subtotal colectomy at the age of about 18. So basically as a child, as a teenager, and she wasn't really aware why she needed that, but was coming for routine colonoscopy checkups or surveillance endoscopy, and was also told she needs a gastroscopy, but didn't really know why. So the history wasn't really that helpful. But on upper scope, so going through the pylorus here, we're going into D1. You'll notice multiple sessile polyps. We're in D1 here, a bit of bile at the top there. And as we go down into D2, you'll notice quite a large number of polyps here as well, all very small, none of them significantly raised, certainly no pedunculated polyps, all quite sessile. And going down further, we try to get as far down as possible. There's even some in D3. And although they look a bit similar to what Galia just showed you in Poitiers, or one of the hematomatous polyps, these actually are adenomas. And so this patient is actually one, although she wasn't fully aware of it, who has actually had FAP and already had her prophylactic colectomy done at a young age. So here we're dealing with a patient with FAP, some 12, 13 years later, which is the typical time period that they present with duodenal polyps. And the question is, well, what do you do about them in patients with FAP?
Yeah, so no upper GI polyp talk is complete without mentioning FAP of the duodenum. As you'll remember, it's the second most common site for polyps in these patients. And as Matt said, it's sort of 10, 15 years later. Very common, unfortunately. And duodenal periampullary CA is the second leading cause of death, unfortunately, in these patients. And their lifetime risk for duodenal malignancy is almost 100%. So definitely worthwhile to not just look at the colon or the remnant of what's still there. Please remember your upper scope. And as Matt said, most commonly in D2, we did have a few here in D1, but D2 and D3, that's where you need to look. I just put this up here. I'm sure you'll all have this on your phones or somewhere where you can look, but remember Spiegelman's classification for duodenal polyposis, very useful. And the things that you need to look at are firstly the polyp number, the size, and again, histology, but you can only get that once you've biopsied, obviously, and then whether or not there's any dysplasia present on your pathology report. You're going to score your patient and stage them accordingly. And this is essentially to assist you with how to move forward. What are you going to do for this person? So stage 1 and 2, that's usually what we see, fortunately. Stage 1, you don't need to do anything. You can just observe and rescope them sort of between every 3 and 5 years. By the time they get to stage 2, it's a little bit more debatable. Do you do anything? Or do you just surveil them again? What is clear is that people start looking at them a little bit more often. Your options are basically to offer thermal ablation. You can do some argon plasma coagulation, so APC. You can offer photodynamic therapy. We don't have that. What is definitely the case with both of these options is that the results are pretty varying. We only are able to offer APC, and I must say we've often got a situation where you initially get the impression that there is some regression, the numbers are less, but within a couple of years, when you go back again, your Spiegelman staging goes back up. So I'm not convinced of their use, but you'll agree there's not much else you can do when there's lots. So yeah, for the moment, we continue with argon plasma coagulation of these multiple small polyps. By the time you get to stage 3 or 4, well, then you have to get your HPB guys involved. And the debate then comes not so much whether you need a duodenectomy prophylactically, but when. Here's just a nice sort of fried egg on the floor appearance, a nice single but largish adenoma, elevated nicely, pretty nice to snare off. Again, as Matt said, the trick here, especially in the duodenum, the wall is thinner than the stomach. So when you do snare that adenoma, make sure you move your snare up and down to make sure that you do not have the entire wall of that duodenum moving with you, because then you know you've caught some muscle tissue with you. And as Matt said, that dye that you put in just beautifully differentiates your mucosa from your deeper layers. Very importantly, for FAP patients, it is not good enough just to do a forward viewing scope. You need to come out afterwards, pop down a side viewing scope. You must take a look at that ampulla and you must biopsy the ampulla. So that's not complete if you don't pop down a duodenoscope.
Okay, and I'm a little bit ahead of time, but for the last case is actually just out of interest. This was an interesting case we saw, which to just perhaps prove that not everything that looks like a polyp is necessarily a polyp. And this was a 31-year-old male who was known HIV positive with a very low CD4 count, so severely immunocompromised, who was admitted with a profound anemia with an HP of 3.4. He also had some epigastric pain, and we were asked to have a look. And this is going down the esophagus. There's already one or two strange looking hyperpigmented areas. And as we come down to the OG junction here, you start noticing what looks like, one might say, a carpet of red polyps. And as you progress, it's involving basically the entire stomach. And interesting, I mean, this patient was still profoundly anemic. You'll notice that the normal looking gastric mucosa looks very pale. That's because the HP was, I mean, they had to transfuse a unit or two, but the patient was still anemic. A couple more red spots, and this process was also present in the duodenum, out of interest, going into D1, and a few spots even down into D2. And then as we come back, I think the retroflexion view that you're going to see now really sums up how extensive this process was throughout the entire stomach. And this is a condition we see every now and then. I think Galia agrees, we've never seen it quite so pronounced as in this case, but this is Kaposi sarcoma in an HIV positive patient. So this is just out of interest. These are not polyps, these are sarcomas, and obviously need to be treated with chemotherapy, etc. So just out of interest's sake, interesting scope to end off.
So just some mistakes to avoid with gastric polyps, and this was put together nicely by Waddingham et al. And the cases we've presented hopefully will sort of point out some of these things to try and avoid. So there's basically 8 things to be aware of. I think our first case or second case, I can't remember, but remember not to miss blind spots. So although you think you're doing a good retroflexion, you still need to torque your hand considerably to see behind your scope. And you want a 360-degree view of your cardia. So remember your blind spots. Then you do need to have some awareness and understanding of both the mucosal patterns and the morphology of polyps. Remember, we need to try and speak a common language between us all so that we are on the same page, endoscopically speaking. So get into the habit of doing that. That is something I need to do and work at. Then inadequate biopsies. Here, I think very important to biopsy the large single polyps. And if you have multiple polyps, don't just biopsy one. Try and get a nice representative idea of what's sitting there. So biopsy quite a few. And then please don't forget to biopsy your surrounding mucosa, both for H. pylori and paraneoplastic situations. In polyps, gastric polyps, size does matter. Resect anything more than 10 millimeters. Check for H. pylori, we said. Surveillance endoscopy always, even if you've got a complete adenoma resected. This is a situation you have to go back. That is pre-neoplastic. Again, second last point, don't forget polyposis syndromes. If you've got loads of polyps, there's something going on, and just make sure that you know and are sorting out your patient before you send them off for a surveillance scope only in 3 to 5 years later. And then lastly, as that other case showed, don't underestimate the presence of synchronous lesions. It's not necessarily the case that one patient might have only one type of polyp. So yeah, I think that's all we have. It's a brief run through sort of the more common gastric polyp scenarios that we would come across, and hopefully how to deal with them. I think, Matt, anything else? Otherwise, we're happy to take some questions if there are any. Thank you.
Thanks very much, Galia and Matt. I think you did a very good job there, very clear in your thought processes. I'm very glad that I'm not an old woman, a mushroom, or a fried egg. So I hope you don't have a polyp that's an analogy for me. For those of you that don't know or can't see me, I have lots of grey hair and I'm pushing 70. So I'm very glad there isn't a polyp to fit my description. So that's just an aside. I do have a couple of questions for you. I don't see anything in the chat box, but my first question to you is, you alluded to these mapping and biopsy protocols at the start. And perhaps you could tell us, particularly in relationship to hyperplastic polyps, you may be worried about H. pylori, but surely you should be more worried about atrophic gastritis. And should you be mapping those patients with hyperplastic polyps, especially those that have quite a few of them?
Yes, I think the answer is definitely you should be. The truth of the matter is I don't think many of us are doing it properly. You just get through the scope as quickly as you can. Let's be honest, if there's 20 on a list, but yes, we should be. And the biopsying the normal background mucosa is ideally done according to the Sydney protocol. And it's something we should get into more better habits of doing. Yeah, I'm a bit of a culprit there. I don't do that as well as I should. And yes, with the hyperplastic polyps in the background, even more so, good reason to do so.
I was very interested in your FAP and the Spiegelman. There was a very prominent surgeon in Durban who actually did a pancreaticoduodenectomy on one of two twins whom he took out the colon when they were in their 20s. And she was 65 when she had her resection. And she basically presented with an obstructing cancer, and she did survive the operation. But I think it's a very difficult decision to make for prophylactic whipples, so to speak. You really do have to have a consensus regarding what's going forward. And I must admit, I wasn't aware that the incidence was 100% that they would develop a cancer. And I do think now some of these FAP, because it's a syndromic thing, they do have different areas of genetic abnormality on the same gene, that I think you can start to have some risk profile also from the genetic content of their mutation and the exact mutation that they have. I don't know if you've got any information on that. Maybe Matt has been reading about it.
I'm not sure, you can tell us, but from my side, I think this specifically, as you say, it's a difficult decision to make. I think Spiegelman stage 4, well, it's sort of a given, you're going one way. I think it's easier, but the stage 3s, it's tricky. And I really do think this is a case for an MDT discussion. It's not something one person should be deciding. I think the younger the patient with a more advanced stage, gosh, I would be a little bit pushed to go forwards. But yes, as you mentioned, or alluding to, a prophylactic duodenectomy is, gosh, that's a big outing. And then there's a couple of things to debate when you do it. Do you then do an ampulectomy as well, or do you implant it? I mean, there's a couple of things to debate in that situation. But yeah, it's a big decision, I think, definitely for an MDT.
I'm not sure if anyone else has any questions. If you would like to raise your hand, and could you possibly stop the screen share, Matt?
Sure.
So we've got a nice collection of 30 people or so. So yes, Chris, carry on.
Yeah, just on the subject of atrophic gastritis, obviously the cancer risk, but also just a reminder to look for B12 deficiency in all these patients, very high incidence of B12, and then obviously follow up with intrinsic factor and parietal cell antibodies to make the diagnosis of pernicious anemia, because obviously that has implications on how you're going to replace B12, but don't forget B12 deficiency in these atrophic gastritides, which often present with polyps as the kind of marker. Yeah.
Thank you.
Thanks very much. There doesn't seem to be any activity from elsewhere. So it remains for me to thank the speakers for an excellent job. And I really enjoyed finding out about a few things I had no knowledge of. And I'd like to again thank the India team, the ECHO team in India who support us, and New Mexico. Just remember that this is recorded and that it's available to you on the Gastro Foundation website. And obviously we can't do this without the many sponsors that are helping us through with the Gastro Foundation and G-ECHO. So thanks to them. And to all of those who are participating, remember, we would like to see similar case reports from you, and we can hopefully try and advise you on the best therapy that we think. You can see that these decisions are not necessarily straightforward, as has been illustrated beautifully by Matt. And so I would encourage you to get in touch with us and submit your own troublesome cases where endoscopy has been proven to be or might be a solution that may enhance the diagnosis or the treatment for that patient. So thanks to everyone, and hopefully we'll see you next week for the GI pathology, hepatic histopathology, and autoimmune hepatitis. So definitely something there for people who are yellow. Take care, and we'll see you in the future. Bye-bye.
All right. Thanks, Matt. Thanks, Galia. Excellent.